Good afternoon. My name is Steve Burdett, and I am the screw-up who came to the wrong day for my lecture, and so I apologize for that. So thanks to my IT support, which is my 12-year-old daughter. Hopefully you are watching this via YouTube at your conference. And to those of you who realize you're now watching a movie recording and are walking out of the room, I just want to say bye. Hopefully we get some good stuff here for you that is beneficial to you. So I'm an infectious disease doctor. I live in a different world than you all in organ transplantation. I was a transplant infectious disease doctor many years ago, but when they shut down your program, there's not a lot of business to be had in transplant. So I do help Life Connections of Ohio as a consultant with some of their complex donors in regards to infectious diseases. So what I'm going to give you today is actually an infectious disease talk. Your lingo in organ procurement is a little different than my lingo, and I don't necessarily know all of your organizations and all of your abbreviations, but what Matt Dewey asked me to cover was just some of the infections that lead to an automatic rule out for your donors so that you can see some of the clinical information behind them and kind of know how they would present. I have no disclosures. And again, I'm going to focus mostly on things that are native to the United States of America. I do have something on Chagas, which some areas will deal with, but we're going to mostly deal with things from the United States. So let's start off with the case. A 32-year-old male was an unrestrained driver. He was ejected. He had been serving 15 years for robbery, and it was during the escape actually that he was injured. Because of his injuries, in addition to his head injury, he had an acute abdomen, so he went for an emergency exploratory laparotomy. And as you can see there over on the right side, the surgeons were concerned, these are actually photos from my library, because within the peritoneum they saw all these white nodules, and they were not sure what was going on. Ultimately, his hepatitis B, HIV NATs were negative. His, not shockingly, Hep C NAT was positive. His chest x-ray did not show anything. And what this turned out to be was actually peritoneal tuberculosis. And when you see that white studding throughout the peritoneum on those four photos, especially the one in the upper right-hand corner, that is consistent basically with most of the time that is going to be tuberculosis. So let's briefly look at TB and some of the risk factors. When somebody has been exposed to tuberculosis, they're at the highest risk for developing active infection within the first 2 years. If you were exposed many years ago, your risk of developing active TB is dramatically lower. And before I go any further, I should just comment briefly on latent TB versus active TB. Latent TB just means that you were exposed to tuberculosis. You are not actively infected, you are not actively contagious, but you test positive for an exposure. Versus active TB, you are contagious if it's pulmonary. You typically have to take 4-drug therapy, whole different ballgame when you're dealing with active TB as compared to latent TB. So other folks that are at risk for active TB, if you've been around somebody with tuberculosis, if you've immigrated from areas with high rates of TB, we see this a lot from India, the Philippines, many of the African countries as well. Children who have a positive PPD test or other tests that we use for TB who are less than the age of 5, they are at risk. Depending on the area of the country, your homeless folks, we don't see a lot of TB in our IV drug abusers, but folks with HIV are at risk. And then folks that work in correctional facilities, nursing homes, hospitals, the risks are variable. Here in the United States, the rates of tuberculosis are very low. So most hospitals now actually don't even have to screen on a yearly basis. But some areas, especially New York City, do see a lot of TB. So it varies by what part of the country you are working in. When you look at actual patients, what their risk factors are from going from latent to active TB, it's folks with substance abuse, HIV, diabetics, patients who have had an organ transplant, and then the big one now, something for you guys to think about in organ procurement, is folks who have been on either steroids or immunosuppressants, specifically the TNF-alpha inhibitors, such as Remicade, Enbrel, Humira, and then there's some newer agents along those lines. Those medicines definitely put you at increased risk. So if you are doing an organ procurement on somebody who has been on Remicade, Enbrel, or Humira, making sure you've done a good TB evaluation, I think, is very reasonable. TB typically presents as pulmonary TB with that cavitary upper lobe lesion. Many of these folks will have had weight loss, fever, night sweats. They will have coughed up blood. Most patients get pulmonary tuberculosis, but immunosuppressed folks, especially folks on Remicade, Enbrel, Humira, steroids, they can present with disseminated TB, TB lymphadenitis, TB peritonitis, things like that. But most of the folks that you're going to see, that you're going to be evaluating, if they have a negative chest x-ray for tuberculosis, or negative chest x-ray, excuse me, for a cavitary upper lobe lesion, chances of TB are pretty low. Another fungal infection which is on your list of automatic kind of exclusions from organ transplantation is the fungus Cryptococcus. There on the left side you can see here some of the risk factors, HIV and specifically AIDS. Usually your CD4 count has to be kind of in the 100 or below range for you to develop Cryptococcus. Discompensated cirrhosis, patients with autoimmune disease, many times because, again, the immunosuppressing medications. Cancer patients, specifically hematologic malignancy. I have seen patients diagnosed with Cryptococcus with various leukemias, weeks into a hospitalization, either as a kind of nosocomial type infection or it just was not identified at the time of admission. And then patients with chronic organ failure are also at risk for Cryptococcus. There is one study out there, though, that shows that 22% of patients infected with Cryptococcus had no risk factors. So this is something that can affect even the normal host. This is one of the reasons why when you guys look at CNS infections or CNS complications for organ procurement, that's if you don't have a specific cause for why they have CNS disease, whether it's a hemorrhage, whether it's a stroke, whether it's an abnormal imaging that has led to them being an organ donor. If you don't have a good explanation, many times you walk away from these folks because one of the causes could be CNS Cryptococcus, and you do not want to procure those folks. It's typically acquired via inhalation. Those of you that work in the Northwest, kind of in the Seattle area, have probably seen a fair number of Cryptococcus because there was a different species of Cryptococcus going through there than we see in the rest of the United States. They have a species called Cryptococcus gattii that is kind of calmed down as best as I know, but there for a while was causing a lot of issues up in the Northwest. It typically presents with CNS disease, so meningitis. You can see there in the imaging, can also present with brain abscesses. These folks will come in again with an unusual presentation for meningitis. You can get pulmonary cryptococcosis. You can see that there in the imaging down below. That is typically the immunosuppressed host. Patients can get cutaneous lesions as well, and that's in the upper right-hand picture there. And some folks just have it disseminated in multiple organs. Again, you're looking at the host, typically immunosuppressed. It's pretty easy to diagnose with antigen testing that can be done on blood or on spinal fluid. But if you have that unusual donor with especially CNS issues, it is something to think about. And again, you can do a cryptococcal serum antigen on these folks. Most labs do them pretty quickly if you do have to evaluate it further. Aspergillus is another one of the do not procure infectious diseases. Aspergillus comes from inhalation of spores. It is found in the soil and is also found in buildings with moisture issues. So any building that has had a flood, any house that has mold kind of in and around the baseboards because of moisture, Aspergillus is definitely something that could be growing there. This is a fungus that is extremely common in the environment, and there's really nothing we can do to completely avoid exposure to this. Your risk factors for having symptoms or being infected with Aspergillus include prolonged neutropenia. In our hematologic malignancy patients, this is definitely something we prophylax against. Patients that are on high-dose steroids, typically more than 30 milligrams of prednisone a day, are at risk. Immunosuppressing medications, such as your transplant recipients. One of the worst cases of Aspergillus I actually had was a tracheobronchitis in a kidney transplant patient, to where the entire unit could hear him coughing because he had a pseudomembrane within his trachea that would flap every time he would start a coughing spell, and it was the most unique, unusual cough that I've ever heard. I will never forget that. And then also HIV and AIDS patients are at risk for developing Aspergillus. It can present with the sinus infections, especially in folks that are immunosuppressed, in folks that have been heavily antibiotic exposed. Again, because it's in the air, you inhale the spores, they set up shop, so to speak, in your sinuses and cause issues. Much bigger issue is a necrotizing or cavitary pneumonia, as you see there in that right upper imaging there. It will be very hard at times to differentiate imaging abnormalities between something such as Aspergillus and then tuberculosis, even Cryptococcus. A lot of these infections will cause cavitary lesions. Unfortunately, may not be all that obvious when you do a chest x-ray, may only be picked up on CT scan. Again, as I mentioned earlier, you can get a tracheobronchitis. There, that middle picture has a CNS infection, and immunosuppressed patients with CNS abnormal imaging. You absolutely must think of Aspergillus. It can cause an encephalitis and a meningitis. You can get cutaneous Aspergillus. And then as you see there on that third picture on the right, some folks will develop an aspergilloma. So if you were to do surgery on that chest and remove that cavitary ball that's in there, that's all Aspergillus. And actually, therapy, antifungal therapy, is actually not all that effective for the aspergilloma. But Aspergillus can have a wide array of presentations. And again, the big concern is the CNS findings. It can cause a hemorrhagic stroke. Typically, though, it's going to be an immunosuppressed patient. So here's another case. I don't know if you guys are anything like Dayton, Ohio, but heroin is just epidemic. So this was a 35-year-old from Ohio who had a anoxic brain injury from heroin overdose. He had skin lesions all throughout his body, which the resident team thought was due to skin popping. His hepatitis testing, HIV, NATs, all came back negative. And actually what this turned out to be was not from skin popping, but he had cutaneous histoplasmosis. So here's a map of the United States. You really cannot speak about histoplasma without talking about blastomycosis. Those two fungi go hand in hand. And as you can see, those of us in the Midwest, including St. Louis where you are right now, that is basically the overlap area for blasto and histo. They're in the kind of the green puke color. There in the bottom, that's where coccidiomycosis is going to hang out. And then I mentioned Cryptococcus gattii in the western part of the United States. But for me in Ohio, one of the biggest infectious diseases that I deal with is histoplasma, followed shortly there behind by blastomycosis. So when you look at risk factors, it really is in people who live in those endemic areas. We've had young donors. We had one recently that we had to walk away from because during procurement they found granulomas all throughout the liver, the spleen, other areas that look like acute and recent infection with histoplasmosis. So it typically presents with pulmonary issues. Again, you inhale this. Many times histoplasma and blastomycosis occur after exposure to something like construction, where they're digging a foundation of a house. You find it in patients who have been around birds, because birds, peck, especially things like chickens, will peck their food out of the ground, thereby eating the histoplasma out of the soil, and then it passes in their feces. And then as you're cleaning out a chicken coop, as you're cleaning out your attic and you find issues with birds, you stir up their feces and you inhale the histoplasmosis spores. One of the worst cases of histoplasma I saw was actually somebody who was working at a Kentucky Fried Chicken doing a remodeling. And when they got up into the attic of the KFC, they found that there had been large quantities of pigeons and other birds that had been living up there. And this guy got a very acute pulmonary histoplasmosis and almost had to go onto the ventilator because of the inflammation in his lungs. One of the under-recognized issues with histoplasmosis is CNS infections. So anytime you have an unknown CNS disease in somebody who doesn't have a lot of risk factors for something such as a hemorrhagic stroke or whatnot, CNS histoplasmosis is something that should be considered. You can get cutaneous infection, especially with blastomycosis. Blastomycosis is definitely prone to causing ulcerations, especially in and around the mouth. So if you have a potential donor who has a tongue or ulceration or ulcerations on their lips, you must think about blastomycosis. And then again, because this is a fungus that you inhale, pulmonary infection, including lymphadenopathy, pneumonia, cavitary lesions, and nodules, all can be seen. This is a common cause in the Midwest of the pneumonia that does not improve with antibiotics. So again, coccidiomycosis, you're only going to get if you're down in the southwest United States, as you can see there in the imaging in the map down in the bottom right-hand corner. This is, again, another soil fungus. It is acquired by inhalation, and typically just simple travel to these areas, traveling to Arizona, being out in the desert, does put you at risk. This is not something that somebody who's never been to the Southwest is going to deal with. You've got to travel to the areas where this fungus is endemic in order to become infected with it. Risk factors for severe disease, again, HIV. This is definitely an issue in patients that are pregnant, solid organ transplant, lymphoma patients. Once again, prednisone, this time more than 20 milligrams of prednisone a day is a risk factor. The dreaded Remicade, Humira, Enbrel, chemotherapy for solid tumors, diabetes, and patients with pulmonary conditions. So again, a lot of risk factors here, and ID doctors down in the Southwest deal a lot with coccidiomycosis. Clinical manifestations, a lot of respiratory stuff, fever, cough, shortness of breath, fatigue, night sweats. You can get a rash called erythema nodosum. Tends to be a little bit more smoldering type of infection. You can get CNS complications from it, but I don't think they're quite as common as what you see with something like histoplasma. But as I mentioned earlier, I don't see coccidiomycosis because I practice in Dayton, Ohio, and I would admit that I see about one case a year. So the ID folks or the transplant procurement organizations in the Southwest are probably much more familiar with cocci than I am. Now, Candida is extremely common, especially in your donors who have been hospitalized for a while. It is part of your normal flora. It hangs out in the mouth, the vagina, the GI tract. One of the big concerns would be candidemia when it comes to organ procurement. While having Candida in the urine is really only a concern for renal transplantation. We did, the American Society of Transplantation did come out a few years ago with guidelines for dealing with fungal infections after transplantation, specifically donor-derived fungal infections. I was one of the authors of the Candida section. And again, if you're procuring lungs, if you're procuring the heart and somebody has Candida in the urine, I'm not worried about that. To get Candida in the blood from a urinary tract infection is highly, highly unlikely. And also our current blood culture media is excellent at growing Candida. And so as long as you have blood cultures in those folks, you have done a very good job of evaluating and ruling out candidemia. So again, risk factors for Candida in the urine would be Foley catheter and antibiotics. Anybody who's been on antibiotics and has a catheter, I can pretty much guarantee you will at some point have Candida in the urine. And then the candidemia, so Candida in the blood risk factors, antibiotics, central lines, abdominal surgeries, total parenteral nutrition, and being in the ICU. Again, I'm very comfortable if the blood cultures are negative, then I'm not worried about candidemia. Clinical manifestations can be anything: sepsis, fever in the hospital. It can cause ocular infections. So a donor or a potential donor who was complaining of visual issues prior to their demise, it may be worthwhile to have an ophthalmologic evaluation to make sure they don't have endophthalmitis from something such as Candida. The other bacteria that can do it is MRSA. You can get thrush from it, and especially folks that have been on antibiotics and are obese, they tend to have cutaneous overgrowth kind of in the pannus or in the inguinal area. So, kind of a fungal roundup here: histoplasma, blastomycosis, coccidiomycosis. Your risk factors for those are all location. So wherever your organ procurement organization is based out of, you'll either have lots of experience with one of those three or you'll have no experience with them. Aspergillus is an issue. Again, immunodysfunction, pulmonary, CNS presentations. You should think about Aspergillus. And again, Cryptococcus in general, immunosuppressed donor presenting with CNS disease. So 2 bugs here real quickly before we get to just a few comments on the heroin epidemic, which is obviously ravaging everybody. Strongyloides, it's endemic in the Tennessee, Kentucky area here in the United States, would be the primary locations. It can also be seen throughout Africa, Asia, Spain, Italy, and the big risk factor for strongyloides is walking barefoot in the dirt. Many folks are exposed to this worm as a kid, have it their entire life, don't have any clinical manifestations until they either get put on immunosuppressing medications or steroids. Okay? Strongyloides presents in the donor asymptomatically most of the time. If you notice a donor has eosinophilia and they've either traveled to one of these areas or they're an eosinophilic donor from Tennessee or Kentucky, strongyloides should be very high on your list. Acute infection would be a rash on the legs because that's how you pick this up by walking in the dirt. Chronic infection tends to present with meningitis. The 2 big things are COPD that gets worse with steroids. That's because the worm is in the lungs. And then also if you see a gram-negative meningitis, so you're working up a donor and it turns out they have E. coli meningitis, that is a very common presentation for strongyloides. The worm hangs out in your GI tract. The E. coli, which is in your GI tract, is on the back, literally, of the strongyloides. As the worm migrates through your body, it carries the E. coli with it. The worm migrates to your CNS, drops off the E. coli, and you get an E. coli meningitis. Hard to see, I'm sure, but the rash you can see there on the left. And then on the right is what you'll see on sputum culture. Where those arrows are, those are called snail trails. And that's where the strongyloides has crawled across the agar, carried the bacteria with it, and deposited the bacteria outside of the normal location for the cultures. And lastly is Chagas disease. Again, this is a vector-borne disease that's carried by the reduvid or the kissing bug, mostly found, as you can see there in the map, where the red countries are colored. So again, Mexico and South America. Is a little bit of the reduvid bug found in southwest or southern Texas. It is mostly associated with primitive housing, and it tends to cause a chronic infection. Those of you that do organ procurements down in the southern United States who deal with a lot of potential donors from the Mexico area or South America probably deal with this quite a bit. Chagas disease has 2 different time courses. There's an acute infection, which is typically 8 weeks after exposure. So again, that's going to be somebody who just came to your area from someplace where this parasite is endemic. It's going to present very non-specifically: fever, rash, muscle aches. It can cause myocarditis. It can cause a meningoencephalitis as well. Very difficult diagnosis to make. Most of the time what you're going to see it in, though, is the chronic form, which the 2 main things that ways that it presents in the chronic Chagas disease is with the megaesophagus and the megacolon. So the esophagus is very dilated and the colon is very dilated. Okay, those of you down in the southern United States that probably deal a lot more Chagas than I do, and the donors that we have done up in Dayton. So let's talk about, lastly, from an infectious disease standpoint, the heroin epidemic. Life Connections of Ohio in 2016, 20% of our donors were due to the heroin overdoses. Now we're up to just under 50%. Our infectious disease service at Miami Valley Hospital, about 50 to 60% of our inpatient consults now are related to heroin and the various complications thereof. So, latest data that I saw showed that Dayton, Ohio was #1 in the United States for heroin overdoses. So, we are really being hit hard by this. This data was provided by UNOS, and this was shared to me, and I appreciate it. And it just shows, again, the staggering increase that we've seen in the last 5 to 6 years in the amount of reported heroin or IV drug abuse. Mostly it's heroin. Again, obviously we have carfentanil going around, fentanyl. In the Dayton area, they do something called Lazarus parties, where they get the Narcan. Folks take so much heroin or carfentanil or fentanyl that they intentionally overdose, and one person's job is to walk around and revitalize people or resuscitate people with Narcan. You know, the idea of Lazarus, of bringing them back from the dead. Just out of control, and again, the numbers are all backing that up. So what do I see as an infectious disease doctor with the heroin patients? Staph aureus bacteremia is far and away #1. We see both resistant and sensitive staph. Again, the complications of Staph aureus bacteremia are anywhere from endocarditis. Right now, we have 3 to 5 tricuspid valve endocarditis on service at any one time. We recently had 5 MRSA bacteremias in pregnant patients that were in the hospital for well over several months, many of them with various complications. Again, blood cultures are very good at identifying Staph aureus in the blood. Most recipients or most patients with Staph aureus bacteremia, the ID doctors are very diligent about repeating blood cultures to ensure that they are sterile. And if you are going to do procurements in somebody who's had Staph aureus bacteremia, you absolutely want to make sure that they have sterile blood cultures before utilizing their organs. We see a lot of oral streptococcus as well. Milleri group streptococcus, Viridans group streptococcus, because the heroin users like to lick their needles or lick their arms before they inject. And the Milleri group strep are major pus formers, so you see all sorts of issues from that. Enteric gram negatives, again, many times they're injecting in the bathroom, so you get genitourinary bugs, so we see E. coli, Klebsiella, and then also because of the water, we see a lot of serratia, horrendous serratia endocarditis with aortic root abscesses. It's an absolutely challenging bug because the serratia endocarditis do not do well without valve replacement, and the cardiothoracic surgeons are so tired of replacing valves in heroin users, and then 1 month, 2 months, 2 weeks later, they're back to injecting heroin. So very difficult bug is serratia. As I mentioned, endocarditis is just, used to be 3-4 years ago, you'd see an endocarditis once a month. It was unique. It was an exciting case for the fellows, for the residents, for the students. And now half of our patients have tricuspid valve endocarditis, and 20% of them have aortic valve endocarditis, and they just tend to hang around forever. Right-sided endocarditis tends to present with pulmonary symptoms. Many of these folks will have septic emboli to the lungs, and they can be quite septic as well. The left-sided endocarditis are the ones that tend to be much more dramatic in their presentation, and many times I think are being evaluated for organ donation because they fire off emboli to their lungs, to their kidneys, to their spleen. They go into kidney failure, they have massive strokes, etc. So again, endocarditis is a real challenge. Spinal infections, most of these folks that are on heroin have chronic pain, and that's why they take the heroin. But you always worry that if they've had staph in the blood especially, that it'll go to their back. They can have osteomyelitis, discitis, or an epidural abscess. This many times is associated with endocarditis, and I always worry about it in heroin users who all of a sudden cannot move or use their legs. You very much worry about a epidural abscess developing. And as I mentioned, abscesses, these folks come in with cutaneous abscesses all the time, typically Staph aureus, but as I mentioned earlier, Viridans group strep, the Milleri group strep love to cause pus, love to cause abscesses, and many times when these things are incised and drained, you will find that bacteria as well. And one last thing before I wrap up here is in our heroin users, we've had several of them who have presented with this unusual neurologic presentation, abnormal imaging that shows kind of like you see in that bottom right, a large area of abnormality. And there's now associations in heroin with mucormycosis of the CNS. And obviously you do not want to transplant somebody with disseminated mucormycosis because an organ recipient would not do well. So this is something to think about in a heroin user with CNS imaging abnormalities. It's just on the differential diagnosis. Again, still rare, but it is emerging. So again, I'm about wrapping up here. I did not put a lot of references on the other slide because a lot of what I just presented to you is from my 15 years of experience as an ID doctor. Some of this stuff was taken out of antimicrobe.org, which is a website that we have, and most of the photographers or the photographs that I put in were from my collection. There's another reference that's one of the kind of the Bible of infectious diseases called PPID, Principles and Practice of Infectious Diseases, that provided a lot of the information. So in conclusion, infectious complications and potential donors can be very difficult to diagnose. It's tough because a lot of the diseases that I showed to you, there is no quick turnaround for testing. So there are times in an undiagnosed patient where you may walk away just because of concern for a possible infection. Makes it a real challenging for you guys to do your job. And again, a clinical suspicion and astute clinical evaluations is necessary to help protect our recipients. With that, obviously, I cannot take any questions. I apologize. I'm not sure if there's one person left in the room or 10 or whoever many that stayed for this entire presentation. But again, my apologies for my mistake yesterday of coming early, and I hope you were able to get something out of this. Thank you very much.